Yeah, so I'm Nataliya Uboha. I'm one of the GI oncologists. I joined UW almost exactly a year ago in October. And thus I am very happy to be here, and I'm very fortunate Dusty invited me to give a talk. And I wanted to give you just a little bit. He wanted me to, this is the title he came up with, The State of the Science. So I thought I'd just give very broad strokes on where the field is going, what's been happening, because I've been very active the last 10 years in colon cancer research. Actually, when I said that similar statement like that a couple of years ago when I was still in training, one of my mentors corrected me. He said, it's been really active for 30 years. It's just the previous 30 years as well. It's just the only drug that we had was 5-FU, and we're trying to realize how to study how to administer it. But there haven't been real new developments in the treatment of colorectal cancer. So I'll just talk a little bit about what we know about biology, because that's really what affects how we decide on treatments. I'll talk about systemic strategies to treat the disease, including adjuvant strategies, and also the goal is cure, and how do we get to cure even for patients in stage 4 cancer. So I don't have to tell you this, but you're probably all aware that colorectal cancer is the third most common cancer in the United States, and it's the third cause of overall cancer-related mortality, most females and males. About 20% of patients are diagnosed with stage 4 disease, which is curative in a minority of patients, and 20 to 25% of the other patients who are diagnosed eventually develop stage 4 disease. So there's a huge unmet need, given how common it is for us to improve on what we are doing and get patients to cure or at least long-term remission.
What is that 5.9% represent?
This is 5.9. I think it's basically it's not patients who are not fully staged. This is the data that's taken over many years, and when they look at the databases, if it wasn't fully recorded correctly or not charted correctly, it's not known. Everybody has a stage, it's just not clearly charted. And so if you look at the literature or even the way we chart, we call colon cancer, rectal cancer, colorectal cancer. And that basically is supposed to include the right-sided colon, the left-sided colon, and the rectum. And then a lot of studies will actually call colorectal cancer. Well, what we know now is that these cancers behave differently. The right-sided and the left-sided, and this has been a big point of discussion in ASCO. We know that patients with left-sided colon versus right-sided colon cancer do differently. Their prognosis is different. This is just the graph to show the survival. So the yellow line is right-sided colon cancer. And we know that patients, for some reason, who have right-sided colon cancer don't live as long as patients who have left or rectal cancer. And so clearly there's a difference in behavior. Even though we call them colorectal, they behave differently. It's probably because we now have pictures. This is not meant for me to go over everything on this slide. It's just to show that what we know now is that there's all of these molecules and all of these pathways that are dysregulated in colon cancer. And depending on where the cell is coming from, different pathways are activated, and there's different signaling cascades that are dysregulated. So we can classify the colon cancer more based on the biology. And so this is kind of the figure from the most recent, one of the recent papers was published in Nature Medicine journal, which is a big named scientific journal. And what they've done, they looked at a big number of colon cancers. They looked at different mutations in these cancers. They looked at how different genes are expressed, and they now put colon and rectal cancer into 4 different groups. So there's now 4 different molecular subtypes. So it's not even based on where they're coming from, whether they're coming from the left or the right, but there's actually just looking at the genes that are dysregulated in the cancer. We can now qualify them as 4 different molecular subtypes. So I think what will happen next is that we potentially will treat the right-sided versus the left-sided versus the rectal cancer differently. We now already know that some drugs work differently depending on whether the cancer is coming from the left or the right side. It hasn't really gone into clinical practice yet. This is the slide from the ASCO meeting in 2016. But at least for me, when I see new patients, in my clinic, I start, even though the treatment doesn't change necessarily yet, I start to qualify them. Is it the right-sided, or is it the left-sided, or is it rectal cancer, rather than stating all-inclusively colorectal cancer? Because I think a few years down the line, this will actually play a role in how you choose the therapy. What's even more complicated is when we look at the genetic profile of cancer and we say, some of you might know about RAS and RAS mutations, all of the cancers are tested for that. Sure, the majority of the cancers look like these white cells. This is kind of representative of what the tumor looks like. And so with treatment, the tumor shrinks. But when the tumor starts to regrow, it's frequently that it's these blue and red and green cells that regrow. So even the tumor in one patient is not composed of the cells that are the same. So it's very, so it makes it more challenging to treat, and again, underlines the importance of studying the true biology of the tumor. And I think that's what the field is heading. I'll talk about it a little bit more in the next slide.
They're not all red, green, and blue.
Oh. So what has entered clinical practice in the last few years? So between 1962 and 1991, there was only one drug approved, 5-FU. And this is actually the drug that was discovered here. There have been a number of other drugs that were approved in the last 10 years. It's important to note that all but one that was approved, TAS 102 was approved in 2015. Actually, the active compound of TAS 102 was also discovered in UW. All but one of them are these targeted agents, which means that really the field is moving not towards development of chemotherapy, but towards really targeting this molecular pathway that I talked about. So some of these target the blood vessels, another one target the signaling, but there's not much research is going to develop a new 5-FU or new irinotecan. It's all about this understanding the biology and targeting these molecular pathways. And with the development of these tumors, really the prognosis has changed significantly for patients. With just 5-FU and leucovorin, the overall survival was on the order of a year. Now, the most recent studies, people live as long as 3 years, and then with a resection of the liver metastases and lung metastases, we have cures, or we have really long survivors.
This is among all stages.
This is for stage 4.
Unresectable stage 4.
And so you might have heard about immunotherapy. I went yesterday while I was putting the last preparation for the talk. I went to Washington Post, the New York Times, and I just typed in immunotherapy. And there were a ton of articles on immunotherapy. This one is from New York Times from 2016. It says, harnessing the immune system to fight cancer. And there's pictures of patients. There's all of this hype. I think this is probably one of the hottest things that's happening in oncology right now, immunotherapy. So in case I don't know what immunotherapy is, I'll just give you one slide, just to give you the basics of what immunotherapy is. And this is taken actually from the Keytruda website. I'm not promoting that drug here. It's just that the pictures were the ones that I like the most. And so the idea is that the reason that cancer cells are abnormal cells in our body, just like cells infected with viruses and bacteria. And our immune system, so this is the T cell and it's lit up, so it's very active, should really be going after these cells that are abnormal cells, just like they're going after the cells that are infected or the cells that are dying, or any other abnormal cell that doesn't belong in our body. But for some reason, our immune system does not recognize these cells as abnormal. And that's the thinking, and that's because these tumor cells have these antennas on them that when they bind to the antennas of the T cells, they make the cell go dark, or that basically inhibits the cell. And so there's these new drugs that are now approved for the treatment of other cancers that are antibodies, or they basically block the antennas either on the T cells, on these immune cells, or on the tumor cells. And when those antennas are blocked, the brake is taking off the immune system again, and the immune system now can go after the cancer cells. And so these drugs have had great success in diseases like melanoma. They have also approved for lung cancer now. They're approved for head and neck cancer. They're approved for bladder cancer. There hasn't been as much success with them in gastrointestinal malignancies or colon cancer. But then we did see some signals, and this was presented last in 2015 in ASCO. And so we know that immunotherapy has activity in patients who have what we call microsatellite unstable tumors. So this is, so the blue line, so what we're looking at here is that is a change in tumor marker level or a change from tumor size. You see that patients, the blue bars, a lot of the blue bars are going down. The blue bars are patients have mismatch repair deficient colorectal cancer. So these are typically the patients have Lynch syndrome most often, or also patients when we test all the tumors, what we call MS microsatellite status. So those patients had either Lynch syndrome related tumors or microsatellite unstable tumors that had a lot of mutations responded to this, but not really your garden variety colon cancers. That was even more pronounced, the response. So this is reduction in the size when you combine two different drugs, two different immunotherapy drugs. The problem is that microsatellite unstable tumors, Lynch syndrome tumors, are a small minority of patients with colon cancer, less than 5%. So what do we do? How do we get these drugs to work against 95% of the patients who don't have microsatellite instability? And that's where a lot of the research is happening right now. And so there was this abstract that was presented at ASCO 2016 that showed that combining an immunotherapy drug, this is the immunotherapy drug, that all have these weird names depending which companies they're coming from, with the other drug, which is a small molecule inhibitor drug, which is not a chemo drug, again, one of these biological agents, actually worked in some patients with colon cancer that did not have microsatellite instability, didn't have Lynch syndrome. And again, this is the plot that shows the change in tumor size. So if it's going up and tumor is increasing, it's going down, it's decreasing. The patient, so this is not the majority of patients that responded, but this is the patient population that had no other treatment options. So the fact that this therapy actually led to a decrease is quite encouraging. This is definitely not a home run. I don't usually use the sports. My talks. That says you're part of the 10.
I'm trying to teach her about football.
But I just moved to Wisconsin. But this is a starting point. This is something that gives us something to work with. And so that's why there's now a lot of trials that use an immunotherapy in combination with other drugs, immunotherapy in combination with radiation, immunotherapy in combination with other immunotherapy agents. Because we think that there's hope that we can use the immune system to target colon cancer as well. And I'll tell you about the protocol that Dusty has opened here that actually is using that to treat colon cancer. The other thing I want to talk about is liquid biopsies. What is liquid biopsy? This is from Washington Post. So, and liquid biopsy. So the idea is that maybe you can detect tumor cells or tumor DNA in the blood. So rather than getting people to go through repeat biopsies and scans and MRIs, we can detect this on a more microscopic level. Because the problem with the scans is, as you might know, that for us to see something in this black and white picture, tumor has to be a particular size, right? It has to be at least a centimeter, maybe half a centimeter in size. So maybe there's a way we can detect things early, and maybe it can change our practice. So there's now a great interest in this field called circulating tumor DNA. You know that tumor cells can, when they die, or when they divide, or when they, I don't know, for some reason shed DNA, they can release DNA into the bloodstream. So now there's technology that can pick up that DNA into the bloodstream just from the simple blood draw. And so wouldn't it be nice if you could detect this early, in particular even in patients who have stage 2, stage 3 disease. So this is a busy slide, but I can tell you just broad strokes about it. So this was a study that was presented in ASCO in 2016. So as some of you may know, stage 2 colon cancer is kind of the field of controversy, because depending on whom you see, you might get a different opinion whether patients need chemotherapy or don't need chemotherapy after the resection. And so what the study did, they looked at the stage 2 colon cancer patients, and they collected their blood after surgery. And they tried to see whether the fact that they could or not pick up that circulating tumor DNA could predict whether they would recur. And what this study showed is that patients who had no circulating tumor DNA, so in green, you can see, had basically 100 to like 90% recurrence free, 90% recurrence rate of disease after the surgery. And those that had circulating tumor positive DNA this was a very good predictor for recurrence. So this really could help us decide, although this data wasn't aimed at that, so this data doesn't show that yet, but the idea is that maybe in the future we'll be able to really decide who needs that 6 months of FOLFOX, if any of you have FOLFOX, because it's neuropathy, it's coming to clinics every 2, it really affects your quality of life. So maybe down the line, you'll be able to look at these, at the blood, at whether there is tumor DNA in the bloodstream, it's just a sip of blood, a blood test, and try to figure out who really needs it and who we really should push and who we can just monitor. So this is a tool development.
And so, that needs to be studied in thousands and thousands of patients to prove that benefit, but this pilot is showing
Right,
very
this is
exciting.
the tool in development. And so I just wanted to add saying that, there's a lot, even for patients who have stage 4 disease, we have a lot of different tools, both from chemotherapy, biological standpoints, immunotherapy that's being developed, and also there's a number of different local regional therapies going from surgery to radiation, whether it's yttrium-90 radiation inserting directly to the tumor, ablation procedures. And what we're really studying right now is what's the order of all these treatments? How do you combine them? How do you do this? What is the best sequence to optimize how well patients do? And so what I wanted to end on is this clinical trial that Dr. Deming has opened here, because it really uses a lot of these different novel strategies for patients with stage 4 colon cancer, trying to get people to prolonged remission, not cure. And what this trial involves is enrolling patients who have resectable metastatic colon cancer. These patients will then undergo radiation to one of their liver lesions, because we know that radiation causes activation of immune response, and the radiation causes inflammation. And so the hope is that when patients develop this inflammation from radiation on its own, then when we add pembrolizumab, which is immunotherapy, we can really help to kind of take advantage of the inflammation that's been caused by radiation, try to attack the tumor cells. Then the patient will subsequently go for resection of all the disease, and then this will be followed again by immunotherapy, hoping to get rid of whatever the circulating cells are. This trial just opened last month. We already have 1 patient on the trial, and we are hoping that this will be successful and we can subsequently study in the larger patient population. But I think this trial summarizes everything I talked about. And also the other thing that Dusty is doing, Dr. Deming, is that when patients go for resections, he can take some of the tumor cells to his lab, and then he can actually look at the microscope and do some studies and see what has happened, how has the tumor changed. So this is kind of taking from clinic to bench and maybe back to clinic.
So we're really excited because this will be one of the largest studies that's ever been done in the microsatellite stable colon cancer population with immunotherapy. And so we'll have a lot of tissue and to try to figure out if this isn't the right strategy, what might be the right strategy. Can we use this as a source of tissue to develop new combinations of therapies?
So this is for MSS and KRAS mutant? Is that what you're targeting?
So it's any MSS resectable
So it
colorectal
doesn't
cancer.
matter any of your other real mutations, it's more
No.
just the MSS.
Exactly.
I'm happy to take questions.
So talking about blood markers, so I was stage 4 when I was diagnosed, but I had that my CA levels were not
Elevated? They didn't
yeah,
correlate with
there was no way to
disease.
track them.
Mine were.
Why would that be, and why do some people have very definitive CA levels and other people wouldn't, and would that affect the ability to use blood tests to determine?
No, this
disease?
blood test, so the CEA is a tumor marker that some of the cancer cells, some of the colorectal cancers secrete. And so it just
Just some.
depends, just some. It just depends on the biology of the tumor. They all look different to the microscope, and some of them secrete CEA, it's a protein, some of them don't. So it really doesn't affect that test. That test looks specifically at the tumor DNA.
So when you're talking about different types, 4 different types of colorectal cancer, is there a difference between those
That's
that do
different.
secrete CEA and those who don't? And would that have a diagnostic or
I-
treatment impact?
I don't think that's something that's being looked at right now. CEA is more, than we follow as a marker to help us look at activity, but it's not really related. There's no treatment decisions that are made based on CEA alone.
So that's
It's just one
interesting,
of the pieces
I've
of
never seen
information.
anybody characterize these new consensus types of colon cancer and the CEA levels. That'd be something interesting to
Yeah,
look
it would be,
into.
because a couple of us had no definitive CEA marker.
And with this circulating tumor DNA, what's actually being done is when the tumor is removed, they're taking the tumor to the lab and figuring out what mutations does it have. So is it a KRAS mutation or a PIK3CA mutation? And then actually looking for that specific mutation in the blood for that specific patient. So
But
it's
it has to have, it has to be different from your regular red blood cell or
Sure,
white
yeah,
cells. And
yeah.
So how's that test gonna be regulated? Is it an individualized test? Is it gonna be like a laboratory developed test that each lab does, or is the FDA gonna approve a kind of complex?
Those are all things that have to be yet to be figured out.
Yeah, it's still very early.
So this is limited to just strictly metastatic disease that maybe involves one organ?
So it has to be resectable cancer.
And limited spread.
Right.
So Dusty, and I'd be interested in this piece too, quickly from both of you. So we're talking a lot with Fight CRC right now about immunotherapy. We're helping convene a work group that Dusty's a part of around looking at immunotherapy approaches. So Dusty, do you want to talk a little bit, and Nataliya as well, about Amino Score and where that word might be coming up a little bit more? Because I think we're starting to hear a little more about T cells, predictability of how immunotherapy will work. I think part of what we're going to be doing going forward is probably engaging all of you a little more in some of these opportunities that when we start to move this further ahead, we really want to engage all of you a little further, so we want to make sure the vocabulary is coming through. Do you guys want to talk a little bit about some of those perspectives around some of those other predictive pieces that we think might be coming in?
Yeah, I think there, even in diseases and cancers where immunotherapy is approved, it's still unfortunately only the minority of patients that respond to immunotherapy. For example, lung cancer may be a little more active in melanoma. So there's a lot of research that's being done trying to understand who are the responders and what is it that making the tumor sensitive to immunotherapy. You know a little bit now that maybe it's the fact that the tumors have a lot of mutations. And so if they do have a lot of mutations, then yes, maybe the immune system will be able to recognize them as foreign easier because they just look more different from the normal cells. That's one of them. And another thing that people look at is that how much lymphocytes they have. How does that environment around the tumor work? And I think it's too early to say whether it's going to pan out or not, but there are some suggestions that maybe we'll be able to use this data to predict responses to immunotherapy, but I don't think there's anything definitive right now.
So I can't say the word specifically. Andy's interested in this test called the Amino Score, which, without getting into a lot of detail, basically looks at the quantity and quality of the immune cells that are kind of infiltrating into the tumor. And there's a lot of excitement about this kind of new pathological assessment in that there's some data that it actually is very good at helping with prognosis. And we're beginning to see some data about potentially it also having predictive roles, and I think most specifically, again, a word I can't say because the tongue is too big for my mouth. Specifically where I can't help but say it. What we're really excited about is its potential to be predictive for immunotherapies, though it hasn't been studied in that setting well yet. A big trouble with that specific test is that it's a fairly involved pathologic procedure to be able to actually perform this immunoscoring, and so it would really have to be kind of a revolutionary type of procedure to get into all of even academic centers, let alone community centers, the procedures and equipment to be able to do this type of score. But it is something that we're very excited about, the ability to look at the both quality and quantity of immune cells in colon tumors.
Because I think, as you mentioned, some of the therapies are so specific for people, which is fantastic, but it's also limiting in terms of how expansive. So looking at these sort of models, I mean, I think one of the criticisms that even the New York Times had written was saying, like, it's a lot of focus for very few. What about everyone else, and when and how is this going to grow? And so I think, we're all trying to consider those and thinking about, of course, outcomes for very specific individuals, but then where's everyone? The MSI, the MSS. So this theme specifically has been coming up a lot, and I think we'll probably hear more about it. And the question is, I think we've all been on the fence of, is it really predictive and helpful, or are there other, markers that might just be as good and might not be as invasive?
Yeah, and we don't even know why it works in some lung cancer. The work they've done, some of the work that was done in some other institutions is depending on where you biopsy, for example, in the lung tumor, you get different amount of lymphocytes and get different amount of expression of this PD-L1. So it's really, I think there's a lot we don't understand right now. Just like with cetuximab with colon cancer, it was 10 years later we figure out that we have to test for RAS and NRAS.
So is it true then that the reason that immunotherapy has not been so effective in solid tumors is that even if you can activate the T cells, they really can't penetrate into the mass of cancer? So even they might be effective on the edges, they really can't get in, whereas blood cancers, where they're free-floating, the immune system, the T cells can attack them more easily. Is that?
I don't know whether that's true, because the first cancer that was studied was melanoma immunotherapy, and it's a solid tumor. So I think it's more about how, and it's very active. I think it's the most active in melanoma. I think it's more about the biology of the tumor. The liquid tumors came later. Liquid tumors is news now in the last few years. The initial immunotherapy was studied was, we used to give IL-2, high-dose IL-2 to melanoma. They still do it at Yale, high-dose IL-2 for melanoma. And then all the studies that these drugs came out first were actually the solid tumors, not the liquid tumors.
Yeah, I agree. It's more of a problem with the immune system detecting colon cancer cells as being abnormal.
So we're only 5 minutes behind. That's amazing!
Yay!
Thank you.
So next we have Dr. Noelle LeConte. She is the leader of our gastrointestinal cancer research team.